All right, today we're going to build your ultimate study guide for mastering diabetes pharmacology. Whether you're getting ready for the NCLEX or you just want to really sharpen your clinical judgment out on the floor, we're diving deep into the insulins, the oral meds, and the injectables you absolutely have to know to keep your patients safe.
So here's our game plan. We're kicking things off with the absolute must-knows of insulin, its onset, peak, and duration. Then we'll get into the nitty-gritty of safety and how to actually administer it. From there, we'll explore the whole world of oral antidiabetics, then touch on some other key injectables and the emergency med glucagon. And to wrap it all up, we'll hit some high-yield NCLEX tips and finish with a clinical scenario to make sure this all sticks.
Okay, before we jump into all the drugs, let's just quickly nail down the core problem we're trying to solve. At its heart, diabetes mellitus is all about insulin. Either the body just isn't making enough of it, or the body's cells are putting up a fight and resisting its effects. Every single medication we're about to talk about is designed to fix that fundamental problem.
Let's start with a big one, insulin. And listen, if you take one thing away from this whole guide, it has to be this action profile. Seriously, understanding onset, peak, and duration isn't just about passing a test. It's what stands between safe nursing care and a potentially fatal mistake.
Think of this table as your Bible for insulin safety. Onset tells you when it starts to kick in, which is your signal to make sure that food tray is right in front of the patient. But the peak, that's the danger zone. That's when the insulin is working its absolute hardest, and the risk for hypoglycemia is through the roof. Just look at rapid-acting Lispro. It can peak in as little as 30 minutes. Now compare that to NPH, which has the super wide, kind of unpredictable peak from 4 to 14 hours. And then you have glargine, which is totally different. It's designed to be a background insulin, so it has almost no peak, giving this nice, steady coverage all day long. Okay, so let's put that chart to the test right now. Which of these insulins has a peak somewhere between 1 and 5 hours? Let's think it through. Glargine? Nope. That's the one with minimal peak, so it's out. NPH, its peak starts at 4 hours but goes all the way to 14, so it's not the best fit. Lispro peaks between a half hour and 3 hours, so that leaves regular. Its peak is 2 to 4 hours, which fits perfectly in that 1 to 5 hour window. The answer is C, regular. This is exactly how you have to think on the NCLEX. So we've got the theory of peak times down. Now let's talk about the real world, the practical side of things. This is all about what you actually do to keep your patients safe, the hands-on skills for insulin administration. The number one complication we are always on the lookout for is hypoglycemia, or low blood sugar. And the magic number you need to burn into your brain is 70. Anything less than 70 milligrams per deciliter is hypoglycemia. It usually happens for one of three reasons. The dose of insulin was too high, the patient didn't eat enough to match the insulin, or they did some unexpected exercise and burned through all their available sugar. Now, what's so important to get here is that hypoglycemia can look different from person to person. Sometimes you get this really sudden, dramatic response. It's the body's alarm bells going off. You'll see a racing heart, sweating, shakiness. But other times it can sneak up on you with these much more subtle signs, like a headache, weakness, or maybe just some confusion. Being a great nurse means recognizing both of these patterns to jump in before things get serious.
So what do you do if you suspect hypoglycemia? First thing, always, is check their level of consciousness. Can they safely swallow? If the answer is yes, the rule is 15 grams of simple carbs, think 4 ounces of orange juice. But if they are not fully conscious, you never put anything in their mouth. The risk of aspiration is just too high. In that case, you have to go parenteral, IV glucose if you've got a line, or a glucagon shot. Okay, here's a classic nursing school mnemonic that is an absolute must-know. When you're mixing insulins, it's always clear before cloudy. The easiest way to remember it is RN, you drop the regular insulin, which is clear, before you drop the NPH, which is cloudy. Doing it this way makes sure you don't accidentally get any of the longer-acting NPH into your short-acting regular vial. And here are some more non-negotiable rules. You have to rotate injection sites to prevent something called lipohypertrophy, which is just a buildup of hard, fatty tissue that messes up insulin absorption. Always, always use an insulin syringe. They're in units, not mLs. Keep unopened vials in the fridge, but the one you're currently using is fine at room temperature for about a month. And the biggest rule of all, you never, and I mean never, mix long-acting insulins like glargine or detamir with anything else in the same syringe. Whew. Okay, we've covered a ton on insulin. Now let's shift gears and talk about oral antidiabetics. These are really the workhorses for managing type 2 diabetes. There are a bunch of different classes, and the real key to understanding them is knowing how they work. Each one tackles high blood sugar from a totally different angle.
Just think of this table like a playbook. Each drug class has a special job. You've got big one needs, like metformin, which basically tell the liver to chill out and stop making so much extra glucose. It's like turning down the body's sugar faucet. Then you have sulfonylureas and meglitinides, which are like a personal trainer for the pancreas. They push it to secrete more insulin. Diazolidine diones work by making the body's cells more sensitive to the insulin that's already there. And finally, alpha-glucosidase inhibitors work right in the gut, slowing down how fast you absorb carbs from your food.
All right, now let's zoom in on the big players in each of those classes. And more importantly, we're going to focus on the major complications and side effects you have to be watching for with every single one of these drugs. You're going to see metformin everywhere. It's the go-to first-line drug for type 2 diabetes. Most people get some GI upset at first, but the really serious complication, the one we're always worried about, is lactic acidosis. It's rare, but it's incredibly dangerous. So why all the fuss over a rare side effect? Because it has a mortality rate of up to 50%. Yeah, 50%. That's a coin toss. This isn't just a side effect, it's a potential catastrophe. The risk is highest for people with kidney problems, because if their kidneys can't clear the drug properly, it can build up to toxic levels and trigger this whole crisis. So with that in mind, patient education is everything. If your patient on metformin calls you, which of these symptoms is a massive red flag for lactic acidosis? Think about the signs: muscle pain, sluggishness, hyperventilation, and somnolence. The correct answer is A, somnolence. That kind of extreme drowsiness is an emergency and needs to be reported right away. Okay, let's do some rapid-fire takeaways for the other oral meds. For glipizide and repaglinide, they squeeze more insulin out of the pancreas, so your biggest concern is hypoglycemia. For pioglitazone, the key word to remember is fluid. It causes fluid retention, which is bad news for anyone with heart failure, and it can also be tough on the liver. And for acarbose, since it works in the gut, you guessed it, its main side effects are pretty gnarly GI issues. So we've got insulin and we've got the oral meds. But there's another group of injectables that aren't insulin. In this section, we'll look at those, and we'll also cover the crucial emergency drug that everyone at risk for severe hypoglycemia needs to know about: glucagon. So these drugs are basically mimics. They copy natural hormones that help control blood sugar. Amylin mimetics, like pramlintide, act like the hormone amylin, which slows down digestion. Then you have incretin mimetics, like exenatide, which copy the hormone GLP-1 to boost insulin release. The biggest clinical difference, and the one that's likely to show up on a test, is that pramlintide can be used for both type 1 and type 2, but the incretin mimetics are only for type 2. And here it is, the rescue drug. Glucagon is a hyperglycemic agent, meaning it does the exact opposite of insulin. It sends an emergency signal to the liver that says, hey, release the emergency sugar stash now. The liver then dumps a bunch of glucose into the blood, raising the blood sugar level. This is the lifesaver you use when someone is so hypoglycemic they can't safely take sugar by mouth. All right, let's pull all these pieces together. In our last section, we're going to focus on making those higher level connections. This is about moving beyond just memorizing facts and starting to think with real clinical judgment, the kind you need to ace your exams and be a great nurse. This is a pro tip, a classic NCLEX safety question that you have got to know. Beta blockers, which are super common for high blood pressure, work by blocking that fight or flight response. That means they can completely hide the early warning signs of hypoglycemia, like a racing heart or shakiness. So your patient might not feel their blood sugar dropping. That's why you have to teach them. You cannot rely on how you feel. You have to check your blood sugar. Okay, let's end with one last scenario to put your brain to work. You've got a patient who takes NPH insulin every morning. It's almost lunchtime, and they tell you they feel shaky and sweaty. They're awake, they can swallow. So what is happening here? And more importantly, what is your immediate priority action? Think about the peak time for NPH. Connect that to these classic symptoms. Assess their safety. What are you going to do right now? That's clinical judgment.